Good evening, and welcome to the King's family, of which we are all part. This is the second seminar organised by the King's College Alumni Association as part of our centenary. The seminars highlight the King's contribution from across the whole academic spectrum to the understanding, treatment, and the impact of COVID-19. Tonight's seminar deals with the national governance of a global pandemic. My name is Cyril Chantler. Sometime towards the end of the last century, I was the Vice Principal of King's and Dean of the Guy's, King's and St Thomas's Medical and Dental Schools. We have two excellent speakers this evening. Professor Ewan Ferlie is Professor of Public Services Management in the King's Business School, and Professor Kenji Shibuya is Director of the University Institute for Population Health. The national governance of a global pandemic clearly has to take into account the world setting, because if one country is unsafe in our global world, all of us are at risk. Likewise, the role of each government plays in mobilizing health and civic resources to contain and suppress the epidemic is of vital importance. Our speakers will consider both of these topics in depth. Each will speak for 20 minutes, and as they do, we will collect the questions that you want them to discuss afterwards through the Q&A function, so do please use it. You can see at the bottom of your screen, and I will then put the questions to our speakers. Before we start, I should perhaps mention that in 2003, I was the co-chair of the Government of Hong Kong's a review of SARS, which report incidentally is available online, along with a paper that we published in the Journal of the American Medical Association, which compared the way the Hong Kong suppressed the virus with the actions taken in Canada at the same time. And in March this year, I had an email from a colleague in Hong Kong who's a specialist in public health. And he concluded with the following observation: public health in Hong Kong would not be where we are today if it were not for SARS. This was back in March. Not for SARS and all the recommendations in the report. Currently, Hong Kong is emerging from its third wave this year and has had 105 deaths. They seem to have this current wave now under control. And those countries that had SARS in 2003 or MERS in 2015, such as South Korea, do seem to have fared much better this time than us. So what are the lessons that we need to learn? So our first speaker is Professor Kenji Shibuya. Kenji is currently Director of the Institute of Population Health at King's. He's been an advisor to both central and local governments, and most recently was appointed as a special advisor to the Director General of the WHO and a member of the Scientific Advisory Committee for Coalition for Epidemic Preparedness Innovations. He was educated at the University of Tokyo and at Harvard, and we are very fortunate indeed to have him here this evening to give us the global perspective. Over to you, Kenji.
Thank you so much, Cyril. My name is Kenji Shibuya. Hello, everyone. I joined King's a year ago, and it's a great honor to speak at the KCLA Alumni Centenary tonight. I'm professor and the founding director of the new Institute for Population Health. The institute aims to enhance interdisciplinary approach to the most pressing population health agenda, both locally and globally. Obviously, COVID-19 is one of them. I'm also a senior advisor to the Director General of WHO. So tonight, I'd like to talk about challenges in global health governance in the response to COVID-19. COVID-19 is not a crisis about health, and it is obviously something much worse. And Richard Horton of the Lancet called it a syndemic. A syndemic or synergistic epidemic refers to the idea that the virus doesn't act in isolation. He said, Focusing on the virus alone is a big mistake. The deadly impact of the pandemic is not caused by the virus acting alone, but interacting with chronic disease like diabetes, obesity, heart disease, and hypertension, all against the background of inequality and poverty. We can't fully control the infection without addressing these factors. Before joining King's last year, I was a professor of global health policy in Tokyo in Japan, and also an executive advisor to Health Minister on global health. And I was heavily involved in the G7 summit in 2016, where the former Prime Minister Abe insisted that Japan should revamp the global health security systems. And we worked extensively with the UK government, particularly with Dr. Sally Davis, a former chief medical officer. To me, the UK has always been a driving force of global health policy making, which I really admire. This is one of the reasons why I came to the UK to run its policy making process, and also leverage my expertise in global health and the UK's excellence in science, diplomacy, and agenda setting capacity. At the 2016 G7 summit, we proposed 3 agendas, and Prime Minister Abe himself contributed to a commentary in the Lancet, but I'm not quite sure who actually drafted this for him. In collaboration with the UK government and other partners, we managed to deliver 3 outcomes out of this G7 summit. First, strengthening WHO's function by creating the new emergency division, and also supporting and strengthening international health regulation, IHR. I'll come back to on the IHR later. Promoting universal health coverage. It is essential to have a resilient health system on the ground to tackle any pandemic. In particular, we supported the process of USC 2030, which is an extension of International Health Partnership, which was initiated by the UK government. And also establishing a coalition for epidemic preparedness and innovation, CEPI, is a vaccine fund with Sweden, India, Wellcome Trust, and Bill and Melinda Gates Foundation. All of them are now critical in the ongoing global response to COVID-19. Also, we know that the UK has been the leading figure in the application of science and technology in global health. For example, in the COVID-19 response, recovery trials on dexamethasone and hydroxychloroquine, among others, influenced the COVID treatment guidelines globally. And not to mention vaccine development and the global partnership to distribute the vaccines in the poorest region in the world. The UK led the development of Gavi and the Vaccine Alliance, and also it developed the idea of Advanced Market Commitment, AMC. Advanced Market Commitment aims at reducing the price of vaccine for developing regions by supplementing research and development cost collectively. So right now, WHO, Gavi, and CEPI are establishing a new AMC mechanism to COVID-19 vaccines, which is called COVAX. So I really like these new ideas and mechanisms, which show how smart and tactical the UK global health policy is. Let me briefly explain the political landscape in the global health at the time of the 2016 G7 summit, right after the Ebola outbreak in 2013 and 2014. One of my mentors, Dr. Tachi Yamada, who used to be at the GSK, and who was the president of the global health at the Bill and the Melinda Gates Foundation, once told me, Kenji, global health is the future of medicine. Initially, I didn't fully grasp what he said, but over the years, what he told me was absolutely correct. First, global health harnesses the joint learning on issues of global concerns, including the pandemic, population aging, and health system development. Because the world is more interconnected and shares common issues. And also global health was rapidly expanding as it was transforming itself from traditional development assistance to more focus on strategic, economic, and security matters. And the players proliferated, not just the public sector and the usual UN, but also private sector, ventures, foundation, civil society, and the media. So global health was no longer just a delivery of the existing services to poor regions, but global health includes discovery and development through innovations. This was facilitated by public-private partnership, such as Gavi for vaccines and Global Fund for AIDS, TB, and malaria, both of which have been supported by the UK government as well. And not to mention the impact of the Bill and the Melinda Gates Foundation has been enormous. Second, despite the growing demands and interest in global health, we faced three major governance challenges at the time. First, there was a tension between national sovereignty and the imperative of international collective action. And second, legitimacy and accountability were not clear, for example, in the case of Gates Foundation. Finally, there was a growing cross-sector interdependence, for example, health and education, health and security, health and trade, and health and global environment, and which goes beyond the highly vertical global health constituencies and players like WHO. So the governance challenge became obvious at the time of the Ebola outbreak. And the third, WHO's influence was declining, both technically and financially. Its budget didn't increase much over the past 2 decades, and many of its resources were not assessed contribution, meaning tax share from member states, but the share of the voluntary contribution from donors was increasing, and they were mostly earmarked. And a large share of WHO's budget came from the US government and also Gates Foundation. So whatever WHO said or did always had to be reflected through the lens of the US interest. And in fact, many of the past directives of WHO's infectious disease control were from US CDC, Center for Disease Control and Prevention. But during COVID-19, despite close collaboration between WHO and the CDC, WHO became one of the major targets of the US administration, and so was US CDC. We know that WHO is not a perfect institution. It's a bureaucracy that places more weight on process and compromise. Also, WHO is a mirror of its member states, reflecting their weaknesses. But WHO serves a vital role in global health. It has the world's best scientists to set standards guidelines for health. And in the poorest region of the world, WHO provides indispensable support. And obviously, WHO needs a stronger, the world needs a stronger WHO to protect the world poor. And obviously, the world needs a strong US commitment to support WHO, both financially and politically. But unfortunately, that is not the case right now. So in short, WHO didn't have enough resources nor power, and still it doesn't. But one of the major powers of WHO is its international health regulations, IHR, legally binding regulations on all countries. IHRs were first adopted in 1951 and concerned only just 6 diseases, classic topical 6 diseases: plague, cholera, typhus, lapsing fever, smallpox, and yellow fever. In 1969, the IHR started to require countries to alert WHO to any outbreaks of these 6 diseases. However, the IHR failed to protect global health security during the SARS outbreak of 2002 and 3 because it only covered all 6 diseases. The 2005 revision represents a major step forward in international surveillance security. Dr. David Heyman, who were at the Public Health England and Chatham House until recently, took a lead in this revision at WHO. The regulations now require countries to report any new illness or medical condition that presents significant harm to human population. The revised 2005 IHR expanded the power of WHO, and the agency now had the responsibility to coordinate global surveillance effort. And also the IHR invoked obligation on member states. WHO member states now have to develop core capacity to deal with major health emergencies. So the framework of global health security expressed in the IHR was crucial for WHO to exercise a pivotal role in the response to COVID-19. And WHO alone has the power to determine a public health emergency of international health concern, we call PHEIC, and the IHR. A PHEIC is the formal declaration by the WHO Director General of an extraordinary event, which is determined to constitute a public health risk to other countries through the international spread of disease and to potentially require a coordinated international response. So the IHR committee can recommend PHEIC, but eventually it is the Director General of WHO who can issue a PHEIC. So it's probably the most extraordinary power that the Director General of WHO has. Also, they must consult the country about the disease threat. They are free to ignore the views or wishes if they wish. So it's a decision of the Director General as to whether there is enough evidence for a PHEIC to be issued. This is a serious power. But it was not necessarily employed effectively in the past. So if you recall, Ebola was first reported in Guyana in December 2013, before spreading to Liberia and Sierra Leone. The infection was also transported to the US, the UK, Italy, and Spain. And Dr. Margaret Chan, then WHO Director General, declared a PHEIC on 8th of August 2014, 8 months after the first cases of Ebola were described. So this delayed response of WHO led to a heated debate on WHO's emergency function and also our commitment to revamp global health security systems at the G7 summit in Japan in 2016. So here is the timeline, a little bit small to see, but which compares the response to SARS in 2013 and COVID-19. So in the case of COVID-19, WHO's Director General declared a PHEIC on 31st January, just 4 weeks after China's official report to WHO. At that time, there were only 98 cases outside China. So this was a big political risk. But I believe that there is no reason to believe that WHO delayed the PHEIC declaration. In the case of 2003 SARS, China reported WHO 3.5 months after the first case, and eventually WHO issued a travel restriction after 5 months. At that time, WHO didn't have a IHR 2005. We should also note that since January this year, there were repeated warnings from Asia on the risk of COVID and its pandemic potential. Here are 2 examples published in The Lancet on the 24th and 31st of January. Both are written by my good friends in China and Hong Kong. On your left-hand side, Ben Kao and Craigers reported that the novel coronavirus infection caused clusters of severe respiratory illness similar to SARS and was associated with ICU admission and high mortality. The severe pneumonia is coming. And Gabriel at Hong Kong University suggested on your right-hand side from his modeling study that independent self-sustained outbreaks in major cities globally could become inevitable because of substantial exportation of pre-symptomatic, asymptomatic cases, and in the absence of large-scale public health intervention. But despite these messages from WHO and Asia, the action taken by European countries and the United States was surprisingly slow. So who was responsible for a pandemic that infected over 38 million people and killed over 1 million already? Is it China, WHO, or national government? I don't have a definite answer, but I think this is one of the key issues for the UK in Ewan's presentation right after myself. But there has been a political antipathy to globalism, an appreciation of the importance of international interdependence, solidarity, and cooperation were fading away. And also a decade of austerity created the conditions for politicians and the general public to look inward For example, Trump phenomenon in the US, Brexit in the UK. Japan was completely occupied with the Tokyo Olympics, Brazil, Italy's five-star movement, all of which are somewhat similar, reflecting populism over solidarity. But personally, the most important reason for the widespread complacency across Europe and North America was that political leaders underestimated the risk of COVID-19. This tendency was not specific to the UK or the US, but can be observed everywhere across the globe. Even within Japan, where the response started very quickly after China's outbreak, there are still and also growing group of people, even among policymakers, who believe that herd immunity is acquired and COVID is just another cold and just let it go. So this fragmentation in global policy and infodemic is a huge, huge challenge to global health governance. So this is why we have been working with colleagues across the globe to run lessons from a series of comparative studies. So this is one of the examples which we just published in the Lancet on the lessons learned from exit strategies for the first wave. So we analyzed for 9 Asia Pacific and European countries and regions. And we found that what matters is trust, clear communication, active case finding, test, trace, isolate, as observed in South Korea and New Zealand, and resilient public health system, and obviously long-term strategy. So to summarize my talk, I started the governance challenge at the time of the Ebola outbreak around 2013, but the challenges right now are much more complicated. So I will finish with one more slide. Recently, we published in the Lancet an open letter to the Japan's new prime minister. Japan also did great in 2016 to take a leadership role in revamping the global health security systems after the Ebola outbreak. But its response to COVID-19 so far is just medical. We emphasize that COVID-19 has posed sector-wide challenges and revealed the fundamental inequalities in the human security agenda. As Richard Holden articulated, COVID is a syndemic and a major challenge to humanity. A human security approach, a fundamental value in Japan's foreign policy that prioritizes protecting human lives, is pivotal in its response to COVID-19. And this is also my key message to restore global collective action, solidarity, and humanity in global health governance. So let me stop here. Oops.
Kenji, thank you very much. All right. Kenji, thank you very much indeed. That was actually a super survey. I learned a great deal from it. Thank you. We'll come back with questions after Ewan has spoken. Ewan, over to you. Ewan is the Professor of Public Management at King's. He's written widely on narratives of public management reform, particularly in relation to healthcare and higher education. He's the co-editor of the Oxford University handbooks on public services management and on healthcare management. And he's a fellow of the Academy of Social Sciences, of the Royal Society of Arts, and of the British Academy. So wonderfully well qualified to talk on the management of this pandemic here. Thank you, Ewan.
Thank you, Cyril. And I'll speak to notes rather than slides, but I've got the notes in front of me. I'm going to take a less rosy view, I think, of the UK in some ways. So I think we've had a bad epidemic. There have been a few successes, but more problems. So the deaths are high, the cases are high, the number of deaths in care homes is high. Germany has done better. There have been a few successes. The recovery trial, R&D, the NHS commissioned Nightingale hospitals quickly. But my question is, did the UK health system on the whole respond poorly? And if so, why? And some people are beginning to look at this. Institute of Government has done some work. I noted that a quick inquiry from the Health and Science Select Committees in Parliament started, I think, today to take evidence. So this is a live topic. I'm going to look at 6 possible reasons, I think, why the system was not resilient, why the system performed poorly. and then conclude. And really, these are questions and issues, I think, for future inquiries, which no doubt will follow. So the first issue is devolution of healthcare competences. We have 4 departments of health in the UK, 4 ministers for health, drawn from 4 different political parties. So Matt Hancock is the Conservative MP for England and the Secretary of State for Health and Social Care for England. And the nations have developed different tracks, both on health policy generally and on COVID. So Scotland and Wales, you'd have seen with the speeches by Nicola Sturgeon and Mark Drakeford in Wales. And Drakeford was previously a Welsh health minister, actually, and before that, professor of social policy at Cardiff University. So he does know about the field. They are more cautious on the whole than in England. And there's been some feeling about poor consultation between London, Edinburgh and Cardiff. So it's got caught up in the argument about devolution and possibly more devolution. And it certainly led to some confusion. There was a nice story about a golf course near Monmouth, which crossed the national boundary. So people were meant to behave one way on one hole and another way on another hole. So the key thing was, where was the 19th hole and could you get a drink, I guess? But it was confusing. Is this good or is it bad? You could argue that it's an opportunity for natural experiments. And although the differences are there, the messages are similar, if not identical. So I don't think that devolution is a major thing that we will have to look at, eye-catching though it is. So second factor I want to look at is possible tensions within Whitehall. So if you look at Whitehall, people distinguish between the core executive, which goes across Whitehall, that's the Prime Minister's units, the Treasury, the Cabinet Office, and the big departments, the baronies, such as the Department of Health. So the question is there a tension between the core executive and the departmental baronies, here the Department of Health? So some political scientists see the core executive as weak and the departmental barons still as strong. I guess it depends a bit on the Prime Minister and the Prime Minister's style. I mean, I see the Prime Minister at the moment quite centralist, and taking interest, for example, in social care. So trying to invade the territory of the Department of Health to some extent. However, there was an interesting case, and it's come back into the news, which was Exercise Cygnus 2017, I think involving the Public Health England. And this was a cross-Whitehall multi-agency simulation of a severe flu epidemic coming from Thailand. It hasn't been published. Indeed, there's a complaint going to the Information Commissioner now, getting it published, but The Guardian managed to publish it while redacting bits of it. So I looked it up on the Guardian website, and the key conclusion was the UK's preparedness and response in terms of its plans, policies and capability is not sufficient to cope with the extreme demands of a severe pandemic that will have a nationwide impact across all sectors. So here we have a cross-Whitehall corporate report which said something important, but it didn't seem to cascade down into the Department of Health or to the NHS. So why is that? Why is there a disjunction between what's happening corporately and what's happening within the department? Another example, the National Risk Register, Cabinet Office, part of the core executive, 2017, clearly signalled pandemic influenza as a very major risk, and also emergent infectious diseases. And this was picked up by Public Health England, that was trying to provide public health leadership to the health system. But there appears to be very little impact, again, on the Department of Health, the NHS, and the social care sector more generally. And social care is a sector of extreme importance in all this. So a tension between what's happening corporately and what's happening within the department. So third thing I want to look at briefly is the Department of Health and Social Care. So it is called the Department of Health and Social Care. Social care is now in the title. That's a good thing, I think, in principle, because there is a major issue about how the two sectors work or don't work together. There is a Minister for Care, Helen Whately, who also leads on COVID, actually. But I hope I'm not offending anybody here, but the Department of Health is traditionally healthcare and rather medically dominated. It doesn't have an instinctive feel for social care, which has been much more the province of local government. And social work, for example, has a very different kind of research tradition from that of medicine. So there are different professions as well. Medicine traditionally rather dominant. I think this was important in spring 2020 with the decanting of elderly COVID infection patients from hospitals to nursing homes. This ignited this whole question of the division of between health and social care. And there's a very nice story, I'm sure it can't be true, about social care providers sourced PPE equipment and tried to take them back through Heathrow, and they were confiscated by customs because customs said that the NHS needed them. So that's another interesting little vignette. And we've been promised a social care white paper for years. I hope it's going to come, but it hasn't come yet. So social care, an extremely important sector and rather neglected. Critics have said Department of Health is rather weak at policy making. So one of the things that departments ought to do is produce white papers in areas of policy concern. So I gave the example of social care, which hasn't happened. And Greer and Johnson talked to it about it becoming a department for delivery. So managerialized, if anything, over managerialized, rather remote from the rest of Whitehall, looking down into the NHS with its high political visibility, preoccupied with intense short-term performance measurement rather than the big issues, strong presence of NHS managers within the department, and heavy reliance on management consultants, including actually in the COVID case, all of which suggests that its creative policy-making capacity may be rather poor. And certainly if you look at COVID, what you see are 2 or 3 kind of lists of action points, but I haven't seen anything more thoughtful, more systemic about how the health and care system should respond. So I think the question marks about the Department of Health and Social Care and its policy-making capacity. So three more kind of key areas, I think, and then I'll stop. The fourth one has also been in the news. Most of what I do is normally extremely boring and extremely technical. So I'm rather bemused to find it appearing on the front page. So so just today we had the complaint to the Information Commissioner, and we have the Select Committee reports. Last month we had the reorganisation of Public Health England, which was abolished pretty quickly, actually, without much consultation, and succeeded by the National Institute for Health Protection in August 2020. All happened very quickly. The new institute has a new focus on infectious disease management and is modelled on the CDC in USA and South Korea. But why? Because the Public Health England was technically was an executive agency of the Department of Health. So it was under its control. It could change its mission. It could clear out its senior management. It could have done that anyway. It is unclear what form the National Institute of Health Protection will take, but it reports directly to the Secretary of State. So I see it as a tightening of political control over a key area. And it's interesting that the interim chair is a Conservative peer rather than a career civil servant. Again, there was a political line there. So there may be governance issues. So will there be medium-term uncertainty, staff churn, and loss of organisational memory, all of which are risks with repeated reorganisation? We saw that in the primary care sector, for example, about 10 years ago. There's also a risk of a narrowing of focus. What happens to Public Health England's health inequalities, obesity, and sexual health work, all of which is also very important. So I do think it would be a job for a researcher to track over the next 2 or 3 years what happens when Public Health England morphs into the National Institute for Health Protection. And there are significant dangers and weaknesses, I think. So reorganisation of Public Health England. Fifthly, the ambiguous role of local authorities in all this. Local authorities took on responsibility for public health in 2012, but this was combined at the same time with a period of austerity in which local government was hit very hard, much harder than the NHS actually. But they have a public health and contact tracing role, at least potentially. And they also have a wider political leadership role. England, more so than Scotland and Wales, but England is a very centralised country. But what's interesting is that some of the big regional political leaders have emerged as important voices. I'm thinking notably of Andy Burnham in Manchester, who's spoken really for the Northwest. And I think that's an interesting development. And so there's an issue about how these big councils, the big Labour cities in the north, how they interact with government and the Department of Health. And again, some tensions there and perceptions that London is being too centralised. And also the relationship with the centralised test and trace. This has emerged as a major issue. Should test and trace be done nationally by outsourced private firms? Should it be done by local public health teams who have boots on the ground? Some perception that the national capacity is poor and that the local public health capacity may need to be beefed up. So that's a fascinating story as well. Local authorities, both in terms of the public health function and in terms of the wider political leadership role. Sixth and final point is to what extent is service delivery joined up? So we've got, if looking at the terrain, we have an extremely wide range of service providers. We have the NHS trusts, we have primary and community care, we have local government, we have private sector providers, test and trace, IT contractors for apps, for example, and big contracts going into the private sector. And some are argued without enough scrutiny. Indeed, there was a political push on that a couple of days ago. Again, another political issue around COVID. So there's a complex mix of testing labs, for example, some in the public sector, some in the private sector. Is the joined up delivery? To what extent does information flow when it needs to flow around the system, or is it blocked? And how does coordination occur? And are the gaps, duplications, and strong boundaries between the many different players within the system? So to conclude, from a kind of policy, organizational, and management point of view, I think this is a very interesting field to explore in greater depth. Although it will not be easy to get interviews with some of the key players. Maybe the select committees will be able to do that, and their minutes of proceedings may be interesting sources in due course. To me, the key thing, 4 key things that I'm interested in, going back over my 6 that I've looked at, is the impact or lack of it of core Whitehall preparedness initiatives. What happens to these cross Whitehall exercises? Secondly, the policy-making capacity of the Department of Health and Social Care, including in social care itself. Thirdly, the medium-term impact of the Public Health England reorganisation and the extent to which there's churn, or whether or not the new agency actually managed to stabilise the ship quite quickly. And the extent of joined-up service delivery on the ground, including the role of local government. So I think it's a fascinating field for politics and also for organisational research. Stop there.
Well, thank you. That's a tour de force. You've covered a wide range of issues, all of which are very important. And we're beginning to get questions in which we will try and answer, but if we can't, then we will answer them, or our contributors will answer them online afterwards. We'll make sure we log them. So thank you. I'd like to start by asking Kenji a question. We know that this epidemic spread much wider than SARS did, and it's perhaps because it's more infectious, or you're infectious with it before you develop symptoms, I don't know. But once the WHO had declared the PHEIC, shouldn't at that point restrictions have been made on global travel, because that's the issue which has really affected the world other than China, because they obviously restricted travel within China.
Yeah, so I also tend to agree that right after this PHEIC declaration, I think, for example, global health community, particularly WHO, should have convened the global COVID summit or something to discuss the common strategy to restrict, for example, border control or social distancing or test and trace and isolate strategies. Now, obviously, for example, lockdown or border control measure is not perfect, but I think the delay in border control from the previous experience in influenza or SARS didn't apply to this highly contagious COVID. So I think you're right. I think the global health community should have issued or at least agreed about the impact travel restriction earlier.
Because obviously, as we come out of this, and we will come out of it, we'll know that it's only a matter of time before we have another one, because that's the way the world goes. And I can remember talking about that 10 years after SARS. So it's really important the world knows, but we nationally learn. And so my question for Ewan is about local government, because we know that most of the money from Public Health England is spent locally, less than was intended, I agree. But if you've got local government responsible for tracing, then shouldn't they also be responsible for testing? I couldn't quite understand why we had a national testing system without it linking to the local tracing system.
Well, I mean, like government hasn't had expertise in testing and that kind of field. I think the key thing is rapid information flows between the laboratories and the public health teams. And I'm not sure that that's been happening.
A lot of the testing capacity is local. I mean, there's lots of molecular biology testing facilities, laboratories near King's.
Yes, no, that would be. I think the Crick Institute is doing local tests in North London, isn't it? So that could be part of the response.
Yeah. Thank you. Now, we have a question about trust, Kenji. This, I think, is very much for you. And if trust is so important as it is, how is it the scientists can't develop a unified view of what's, if not necessarily what's right, but what's wrong? And how can you trust science when they all have different views and maintain them in spite of evidence to the contrary? I think I've paraphrased that reasonably well, but we'll get a more specific answer.
That's a very good question, because what we meant in about trust in our Lancet paper is more on the trust in the government. But I think we see every day on the internet or TV, there is disagreement among scientists and totally extreme views. And also that is fueling the trust in science or governmental responses among the general public. So that is not specific to the UK, everywhere, as I mentioned in my talk. So what the science could do, obviously, source of this disagreement stems from uncertainty, and we don't know much about COVID still, although we are, gradually understanding the problem of COVID asymptomatic, pre-symptomatic transmission. A pretty large share of the infection is due to asymptomatic transmission. And long COVID, it's not just death, but the long-term consequences, reinfection. And of course, there is the issue about herd immunity or case fatality ratio. But I think, first of all, the scientists, particularly advisors, should acknowledge the uncertainty, and also they should be clear about what we know and what we don't know. And the secondly, I think it's extremely important for the scientists to make explicit about why these disagreements exist, right? So otherwise, it ends up with emotional debate, and just, these slogans or policy propaganda will be easily used by many policymakers to disrupt the society, and which is happening everywhere these days. So I think one of the key lessons from this is that scientists should acknowledge the disagreement, but at the same time, they have to make it explicit about why these disagreements exist and continue to discuss and make it all the information should be available to the public in a transparent manner. Particularly if you look at response in New Zealand or South Korea, all scientific advisors, of course, I know the friends, and there should be a bunch of heated debate within the advisors body, but once they agree, they stick with it. And also at the same time, South Korea, and as you mentioned, Cyril, about Hong Kong, their scientific level is just exploding. Their scientific and academic publications or the analysis are just global level. Yeah. So I think that reflects also the commitment of the scientists and also the link between the science and the society is working pretty well in this region. Although, of course, the national policy system is slightly different, not necessarily democratic, but the power of science we see in Asia, it's just growing very, very rapidly.
Yes, well, I was aware of that with SARS, and it was amazing how quickly they identified this completely new pathogen of a virus which wasn't thought to be pathogenic in anything like that way. It was astonishing, and I was surprised that we in the West didn't pay more attention to the learning which was available to us back in January, February, but I agree with you. We have a question about why, if it's so important, which it is, as Ewan said, for the national and local to talk to each other and learn from each other and work together, do we have the conversation of negotiations and deals going on about resource? Surely at a time like this, the local and the national should be working very closely together and supporting each other. Ewan, what do you think about that?
Well, there's a party political thing here, isn't there? I mean, there's kind of the big cities tend to be Labour, and we've got a Conservative central administration, and I also think there's a distrust of London, and I think all these things are swirling around in the background, make cooperation more difficult, and I think we've seen that over the last week.
Then another question that comes from that is, whose job is it to ensure that it's all joined up? I mean, how are we going to approach that?
The question is there a prime player in the system? And at a strategic level, I think that should be Department of Health and Social Care in devising an architecture which brings people together. So, I mean, there might be, in some sectors, there are regional partnerships, aren't there? Or managed networks, which are chaired by bits of the NHS, but which bring players together. I'm thinking of managed cancer networks, or for example. So there's governance rather than direct control. The disadvantage of that as well, it takes a long time, lots of negotiations, but kind of steering a complex system. And I'd like to see more thought from the Department of Health about that, really. And
you would think that as we learn the lessons, which we must do, that might be a topic that political governance needs to take account of.
Political governance and also organisational governance. So how do you get health and social care to work together? And then you've got a private sector. If you look at nursing homes, for example, good voluntary sector. It's a very complex, multi-sectoral field.
Yes, well, you've made the point that social care is very much, and rightly in my view, the responsibility of local government, but we've got to get health and social care coordinated at the neighbourhood and local level, I agree. We have a question about economic health and approaches to managing pandemics. Presumably this is a reflection of the fact that if a poor country has to manage it as well as a rich country because we're a global world. So how do we work that one through, Kenji?
Yeah, so for example, all the countries, I think there seems to be the debate about trade-off between health, infection control versus economic activities. But given our experience and also analysis from the Asia-Pacific region, for example, if you look at Taiwan, South Korea, and New Zealand, and China, the countries which suppress the transmission, we have very limited economic loss. So I think there seems to be, there is no trade-off between health and economic activities. But I think it's better to suppress and then avoid long-term economic loss rather than taking a balance and just doing some infection control. But let's eat out, help out, let's eat out and continue economic growth. It's very difficult to do that if you look at the situation in the UK or in Europe now. So I think it's extremely important to suppress as much as possible and maintain economic activities with expanding testing, tracing, isolation. Otherwise, we will continue this kind of resurgence, flare-ups, and some sort of local lockdown, which really damage the economy.
Yesterday, there was an article in the Wall Street Journal looking at the management of the next pandemic and what were the principles that needed to be recognized and applied. And the advice that was being given by Jeremy Farrar here and in the United States was we've got to be much better at early recognition and then suppression by testing and tracing locally so it doesn't get out of control. Do you think that we've been too slow to recognize that and too reliant on the notion that we'd come up with a vaccine that would work because we are particularly interested in influenza from our previous experience? I'd like to ask both of you that, please.
I think the system was slow to respond, yes. I mean, again, an anecdote. I think it was in March, there was a big increase in cases on a Friday, and the news was that COBA would meet on the Monday. So I thought, why Monday? It didn't signal urgency, and I think we were late.
Yeah, I'd like to go back to Cyril's point about Asia, particularly Hong Kong and South Korea and China. So they prepared for this kind of stuff for the past 2 decades. So they are well prepared. So a sense of urgency was different and the system was in place. So preparedness is quite different. But I think particularly the UK is delayed for more than 4 to 6 weeks because they were informed of the, this COVID is coming and it's very risky. And there is a global pandemic potential, but it's an ad hoc, post hoc assessment. But I think obviously it was delayed.
Diana Garment, who's very important in the Alumni Association, welcome Diana, asked a very important question. She says, well, if other countries have coped better, should each of us be looking to them for their advice to shape our behavior rather than the advice we're getting from our government? So what do you feel about that, Ewan?
Well, I think it's always interesting to look internationally. I mean, the problem with the Southeast Asian countries is there's a very different cultural context. I mean, Germany might be an interesting one to look at.
Right.
Much closer to home. I mean, there have been bad examples in Europe as well, France and Spain. So it's not just the UK that's performed poorly.
Can you just say about Germany, what's very particular about Germany from governance point of view?
Well, from a public management point of view, it's seen as Weberian, so very, very rule following. That may be an advantage in this circumstance. So I don't know that citizens are likely to be more compliant, and government is seen as having a sort of kind of a role as the protector of the special interest, of the public interest. So it's a different notion of the state. But again, there you've got a big division of power between Berlin and the Länder. So you've got the regions. The regions have a lot of power. The big regions. So it isn't a simple unitary state. It's got two tiers of government. So how did they make that work? I don't know, but it's interesting.
Right. What about common sense? We're asked. Is it always the case that the public have perceived the advice that we've been getting over the months as fitting with reasonable common sense, or sometimes there's been a disjunction between what we're being asked to do and what we're hearing from other places that they're doing, which is different?
Yeah, as Ewan mentioned, it's quite regional or culture specific. For in the case of Japan, wearing mask is a no in the winter. It's a common sense for us.
Yeah.
Not here, but luckily in the case of COVID, mask did work,
Yes.
but not for influenza or others. So I have been very skeptical of wearing mask, but I wear mask all day now.
Yeah.
So
Yes.
you could call it common sense or specific tactics, but I don't know. It depends.
Ewan, we're asked, if you've got a devolved government system, as you mentioned at the start, does that make it easier to link into local authorities or more difficult? It does seem we've found ourselves with a certain amount of confusion between national devolved and local government. Is that going to be part of the sort of research that you'll be doing to learn the lessons?
It's a good question. I mean, what's the relationship between the government of Edinburgh and, say, Glasgow City Council? We don't. I mean, I haven't perceived that the same tensions. Maybe Glasgow's SNP controlled, as is Edinburgh. So you haven't got that different party thing going on. But you would think that in devolved governments, it's a smaller system. They should be closer to local government, other things being equal. So
we have 32 boroughs in London, and they are responsible for social services, not the
yes.
mayor of London.
Yes. Well, they commission it.
Yes.
I mean, the providers are independent providers.
Yes.
I mean, there's been
Ever since Roy Griffiths did a report in,
yeah.
I remember well, in 1988. Yes.
Yeah. The London boroughs are pretty invisible, aren't they? It's more the mayor,
yes,
Sadiq Khan, that's visible.
Yeah. Right, we're coming to the end. Kenji, last words, and then Ewan, last words, and I'll sum up. Kenji?
Yeah, my biggest worry is people will just forget after this. So I think it's important to start preparing for the next, at least right now.
Mm-hmm. Yes. Well, as I mentioned, Hong Kong government launched their review of SARS before I think it had been finally been declared over by the WHO. And we reported by the end of the year, in October, I think, of 2003. So not waiting too long. My personal view is we don't want to be waiting for an inquiry like the Iraq War. We need to get on with it and learn. Ewan?
Yeah, I agree. And I think the initiative by the two select committees is a good one. So that's getting some sort of inquiry going very quickly.
Good. Well, thank you both very much. And thank you all our participants, of which there have been a large number, and we're most grateful for that. I hope it's been helpful. If we haven't answered the questions, and particularly the first question we couldn't deal with in detail, we'll attempt to do that. But thank you all. And we're looking forward to next week, because there are, I think, 6 of these seminars. And the way they're developing, I think they're going to be very useful, not only for us, but also for wider learning. So thank you all very much, and hope we'll all see you again next week. Thank you. Good night.
Good night.